1. We are live now.
So, good morning, everyone. The purpose of this research round is we want to present the clinical research, which we have been doing for around 4-5 years now, more than that. And this paper was presented in the Pediatric Orthopaedic Society India meeting. And there are a lot of questions and queries about this. In a very short time constraint, we have to present this scientific work. Basically, it was in about 7 minutes, which is fairly less time. So I thought that let me put this subject here and we can have discussion on it. I can answer, and that's how we will get some clue and it will make our manuscript robust because it's in the way of publication now. So let me share my screen and once I present, then we can discuss at the end, or you can stop me also whenever you feel like. Okay, so I hope everyone is able to see my screen. Meet?
Yes, sir. The screen is visible, sir.
Okay, fine. So this test, we have termed it as an elbow block test. And so far we have been discussing posterior subluxation in brachial plexus palsy, typical C5-6 palsy. I want to draw your attention to anterior instability or anterior subluxation of glenohumeral joint through this paper. Now, we all know that proportionate limitation of shoulder external rotation and abduction is a typical clinical sign of C5-6 or Erb's palsy. These patients have a common phenomenon that their passive external rotation is limited and they have internal rotation contracture, and this leads to limitation of external rotation. And many a times they have limitation of elevation as well. Some of them, although they show good elevation, but most of them have limitation, which is due to this biomechanical issue where the deltoid is not in a good position to lift it when it is internally rotated. The lever arm of deltoid is shorter, which prevents them to carry out the usual elevation. So typical clinical sign in C5-6 palsy is proportionate limitation of shoulder external rotation and abduction. However, we found a few patients in a specific cohort that patients had good degrees of active as well as passive external rotation, both with arm abducted and adducted. But when we asked them to elevate, that elevation was limited to 90 degrees and they simultaneously flex their elbows. So the question was, this is the subset where they have very good degrees of active external rotation, but they have limited abduction. So what can be the proposed etiology of this limited abduction in the presence of good external rotation? Is it due to limited innervation of abductors in isolation, as described by Al-Katan, or there is co-contraction between shoulder abductors and adductors? Furthermore, we found that when we placed an elbow extension splint, or what we term it as a paddy wrap, the elevation improves spontaneously in all these patients. We have described in this test in one of the journals. So this was a very striking phenomenon that what happens when we put an elbow extension splint, it improves these abductions spontaneously, which proves that neither the abductors are denervated, nor there is co-contraction between shoulder abductors and adductors. So this test where blocking the elbow flexion during elevation induces some biomechanical changes at the shoulder joint and improves shoulder abduction spontaneously is termed as elbow block test. And the aim of this study was to understand the biomechanical basis of this phenomenon. Neet, can I request you to mute other participants if they cannot?
Yes, I muted them.
So the aim of this study is to understand the biomechanical basis of this phenomenon and to identify the patient cohort in which this test is positive and to find out what is the clinical application of this test. To study this, we have been doing this test since 2014. There were 550 patients. We included only those whose age was more than 18 months so that they can follow the instruction, they can follow the test. And in those patients whose abduction was less than or equal to 90 degrees at the outset. Out of this 186 patients, we excluded those patients who undergone previous either nerve surgery or shoulder rebalancing surgery, and the ones with panplexopathy whose abduction is usually less than 30 degrees. So it led to 105 patients, and their average age was 2.5 years, ranging from 1.5 to 18 years. What outcome measures we used? So we measured the degrees of improvement in elevation after elbow block test. We use 6-point modified Maulin score as described by Scott Cousin, which also includes hand to belly function. We measured the strength of muscles of upper extremity with MRC scale and measured the range of movement at the shoulder and elbow joint. And finally, we carried out dynamic ultrasound and CT scan to see the biomechanical changes happening at the shoulder joint. One common trend we found is the patients with internal rotation contracture, they did not show great improvement with this test. And so first we decided to plot this improvement in elevation after elbow block test based on the degrees of passive external rotation. We all know that when the passive external rotation reduces below 60 degrees, this is the beginning of internal rotation contracture. And so we saw and compared the improvement in elevation in patients with presence of internal rotation contracture and absence of internal rotation contracture. And the first thing we found that the patients with less than 60 degree passive external rotation, their average improvement in elevation was only 10 degrees, ranging from 0 to 15 degrees. And these were termed as group A. While the patients with passive external rotation more than 60 degrees or in the absence of internal rotation contracture, the average improvement was 45 degrees, ranging from 30 to 65, and they were termed as group B. Based on these findings, we could define what is a positive test and what is negative test. So positive test was defined as when the primary abduction is less than or equal to 90 degrees in presence of good external rotation. And after paddy wrap application or elbow extension splint application, the improvement is more than 30 degrees. When this improvement is less than 30 degrees, this was termed as a negative block test. And now we studied all the patients in positive and negative elbow block test cohort. So we try to find out what was the patient characteristic when their elbow block test is positive and how they are different from the negative elbow block test patient cohort. We had around 58 patients with negative tests and 47 with positive tests. The age and the average pre-test abduction was matching. So both these groups were matching in this regards. When we looked at the 6-point modified Maulin score, we found that the global abduction was significantly low in patients with positive test, and global external rotation was significantly higher in positive test when we compared it to negative test. while hand to neck, hand to spine, and hand to mouth were statistically non-significant. The hand to belly was significantly low in positive test patients, suggestive of the patients with positive tests had some degrees of weak internal rotation. Furthermore, when we checked the strength of muscle, we found triceps weakness in about 83% of patients with positive test, while it was only in 88.6% in negative test. So triceps weakness is one of the key points. Wrist dorsiflexion weakness was found in 25% of patients with positive test, while it was not seen in the negative test patients. And elbow FFD was found in 39% of patients in positive tests, while it was present only in 10 patients with negative tests. So all these three differences in the active and passive range were significant. Furthermore, when we tried to passively internal rotate the arm while the child's shoulder is 90-degree abducted on the bed, or while child is standing, we found that in some of these kids, we could not passively internally rotate this completely, which suggests that they had some degrees of posterior capsular contracture or external rotation contracture. We found that the patients with negative elbow block test, we could do passive internal rotation in all of them. But with a patient with positive elbow block test, there was average 20 degree of restricted passive internal rotation, which ranged from 10 to 45 degrees, and it was seen in about 40% patients. So this was again a striking feature. We have been checking passive external rotation in all our patients, but when you have to check passive internal rotation, you have to elevate the arm at 90-degree, and then you have to turn this forearm down and see how much distance or angle it makes from the anterior trunk line. And that angle we have to measure, and that is a sign of posterior capsular contracture or external rotation contracture. So this cohort brought different clinical findings when we compared it to the negative elbow block test or kind of C5-6 patients. So when we did the ultrasound dynamic study while the child was sitting, so we first did the ultrasound in the resting position, then the child was asked to elevate whatever the amount of elevation is there. And then we placed the elbow block splint, and then we checked. So what we found that at resting position, the distance between the acromion and cartilaginous humeral head is 0.49 centimeters. When the child lifts the arm, it reduces to 0.37 centimeters. Now, and we all know that with the increasing abduction, the center of rotation of the humerus gradually descends down. It goes down. And so by that mechanism, the greater tuberosity is cleared of acromion. So ideally, this distance should increase. But in these patients with a positive elbow block test patients, we found that this distance was reducing at the outset, but when the moment we put a splint, this distance increased to 0.99 centimeter on an average. So this means that placing an elbow extension splint gives some form of supero-inferior stability, and by lowering these humeral head in the glenoid, it leaves more elevation. So that was the one phenomenon we found in ultrasound. When we posted these children for CT scan, as we do not have an EOS machine or standing CT scan, we had to resort on a supine test. So at rest, we found then in the patients with positive elbow block test, the glenohumeral articulation was normal. The moment we asked the children to elevate, we found that there was anterior subluxation of humeral head in front of glenoid. And furthermore, when we placed an elbow block test splint, this humeral head reduced, the glenohumeral articulation normalized, and elevation improved. And this striking feature suggests that there is anterior pseudo escape, anterosuperior pseudo escape when we try to lift it in these patients. And when we put an paddy wrap or elbow extension splint, this pseudo escape reduces and the glenohumeral joint reduces back. So it is giving anterior stability by putting this brace on. I hope you all get this point well. This slide is the crux of this test. So if we discuss this paper, that we found that the patients with positive elbow block test has more degrees of active as well as passive external rotation, and they have more limitation of active as well as passive internal rotation. So they have more affection of internal rotation rather than external rotation, which we typically see in C5-6 palsy. Furthermore, we found that all the C7 recruited muscles like lower subscapularis, triceps, wrist dorsiflexion, they saw weakness, and thus the C7 element was quite a character of positive elbow block test patients. So I found that the C5-6 patients, this positive elbow block test is more of a phenomenon seen in extended Erb's palsy or a predominant C7 palsy than a typical C5-6 palsy. Now, our own Dr. AK Saha from Calcutta have studied this dynamic stability of glenohumeral joint in great details. And if you're interested in learning this subject, I must recommend this paper to all of you that was published in Acta Orthopaedica Scandinavia in 1971. And there's such a phenomenal knowledge this gentleman had at that time in the absence of CT and ultrasound. And they have mentioned that the subscapularis in front and infraspinatus from back plays a very important role as a stabilizer of shoulder while we abduct the limb. The subscapularis contraction starts right at the degrees of 60 degrees, and it keeps on doing till 150 degrees. So the subscapularis is a very important anterior stabilizer. In the presence of its weakness, which we see in these patients, there will be a phenomenon known as anterosuperior pseudo escape. And this phenomenon happens somewhere between 60 and 90 degrees when the child tries to lift. As the subscapularis could not restrain the humeral head in front, it subluxates anteriorly, which we could prove through our CT scan study. And the moment we put this paddy wrap, somehow this the humeral head comes back to its original position in glenoid, and then elevation improves. Thus, elbow block test reduces this anterior pseudo escape, and we should regard the positive elbow block test as a clinical sign of anterior shoulder instability. Now, we do all the interventions usually for the typical Erb's palsy to improve posterior shoulder instability. We do anterior capsular release, we do tendon transfer behind so that the posteriorly subluxed the humeral head sits back in. But now to improve elevation in this cohort, we should do interventions to improve anterior shoulder stability. We have to correct the anterior subluxation. And the conventional surgeries, as I mentioned, they are focusing on improving posterior shoulder instability. So if we perform the typical anterior capsular release and posterior tendon transfer, it would worsen the outcome by not improving elevation in this cohort of patients. So the future directions from this test is we must consider tendon transfers to improve anterior shoulder stability. This is an example where the child elevation improved after putting an elbow block test splint from say 60 to 180 degrees. And we performed pectoralis major transposition in this patient. We took the clavicular part of pectoralis major, shifted laterally, and stitched to the greater tuberosity of humerus. And you can see the elevation at 1 year, and she improved further. And at 4 years, her elevation had improved substantially. So this study is already on the way, the pectoralis major transposition, but we have started doing tendon transfers to improve anterior stability. We have also found as a patients where they have significant posterior capsular contracture or there is significant limitation of passive internal rotation, the results of pectoralis major transposition were compromised. And so we also do arthroscopic posterior capsular release in these patients to improve their passive internal rotation. What it probably does, it led the anteriorly subluxed humeral head to come and sit within the capsule. A tight posterior capsule pushes the humeral head in front and add to the anterior end stability. So in conclusion, we must identify disproportionate limitation of shoulder abduction and external rotation in our clinical examination. What I mean is if a child comes with good degrees of active external rotation or they can reach to the occiput easily, but their elevation is limited and their elbows are flexed like this, we must subject them to the elbow block test. We have found this cohort incidence of this population is about 15% in our study, meaning that one child at every 6 child with residual brachial plexus palsy have this clinical examination, which is very common. And if we just keep on doing the same tendon transfers in all the patients, then the result would worse the performance of these children. So once these children are positive for elbow block test, we have to consider anterior transposition of the pec major. This is the result here. Yeah, so this is the outcome of this girl. You can see her elevation improved spontaneously after pec major transposition, and I did the teres major to infraspinatus transfer in this case because child had difficulty in reaching behind the occiput a bit. So a double tendon transfer was done in this child and helped her in improving elevation. So in conclusion, the positive elbow block test indicates anterior shoulder instability, which is observed in extended Erb's palsy or in predominant intermediate C7 palsy, and it influences the treatment strategy to a great extent. We all pediatric orthopedicians and physiotherapists have this tools in our examination kit, but now we have to have all the sizes of this paddy wraps or elbow block test splints in our clinic setup if you are dealing with brachial plexus children, because every 5 or 6 patients you will find one patient, so you have to test their elevation when the elbow is constrained with an elbow flexion splint. So thank you very much for your kind attention. So now this paper is open for discussion, and I sort of invite your questions. I will be pleased to answer those. And you can ask the most silliest questions coming to your mind. I'll be very happy to answer them. If there are any, yeah, so that's me. Yes, Gaurav, please go ahead.
Yes, sir. Am I audible?
Yes.
So I have a couple of questions. First question is that the phenomena which you told is anterior superior pseudo escape. So anterior, we can understand that anterior will improve with pec major transpositioning. What do you think is the reason for improvement of superior pseudo escape with anterior transposition?
The one thing is we must understand that when we shift the pectoralis major clavicular part, or let us first see what is happening with the test, So there are a few hypotheses, why this elevation improves. Now we know that when we apply an elbow extension splint, elevation improves. But what biomechanical, and we could prove this through the ultrasound studies, but what biomechanical or changes happening? So my hypothesis, or what I feel, is only the muscle which crosses both the joints, like elbow as well as shoulder, can induce this change. So I felt that the long head of biceps should be the culprit. Now we did surface EMG in all these patients to see whether there is any co-contraction. And I found that there was no co-contraction between adductors like pec major and deltoid, or dorsii and deltoid, but we found co-contraction between the biceps and deltoid. So due to aberrant innervation, these two muscles, they contract together. And long head of biceps is also considered as one of the important anterior shoulder stabilizers. While we put an elbow extension splint, due to co-contraction, the biceps is still contracting. Now, as we constrain it at elbow, its action is more focused at the shoulder joint, and that biceps long head probably helps in stabilizing the shoulder joint in front. And as you can see, the insertion of biceps, it has an effect to bring the humeral head down to some extent as well. So that might be the reason of supero-inferior stability. And the same thing, when we do the pec major transposition, the direction of transfer is we stitch it to the greater tuberosity. And you see the course of it, it is a bit proximal from where it is originating. And so I feel that is giving the stability in both in the front as well as from the supero-inferior aspect.
Sir, one more thing is, have we assessed the greater trochanter and acromion process and tuberosity distance after PMT?
So that's a great question. Like we have to do this test in these patients. Actually, what happened that we have tested this in about 10 patients each. So we should now do this testing in all those patients where we did the pre-surgery testing.
Right.
So we have not done it yet, but we will do. In isolation, I have done in a few patients where I found that this distance is more, but I do not have the findings of pre-surgery. So I am looking for those patients where I have done surgery and we have finding, and now we have finding post-operatively as well.
Right.
So that's
sir.
a good suggestion.
A few more questions. Can I ask them?
Yeah, please go ahead.
Yeah. So another question is, so before we invented this test, do you remember any patient of yours or any of other surgeons where the child deteriorated after conjoined tendon transfer, the pec major, latissimus dorsi and teres major transfer?
Well, I mean, I won't say deteriorated, but they did not improve in abduction. Okay. So there were many patients where they had good degrees of active external rotation, but as we did not know any other operation, we did the isolated tendon transfers. Now we know that passive external rotation is more than 60 degrees, so we are not going to do subscapularis release. So in typical of palsy, the moment we do tendon transfer, we see that there is improved elevation also. But in these patients, they are stuck at 90 degrees. And I remember a few patients where I've done trapezius to deltoid transfer after conjoined tendon transfer, thinking that this deltoid power is not there. Okay. But even after that, after Saha's transfer also, elevation did not improve. So we were clueless that what is happening. Like we augmented deltoid power, we did the tendon transfer behind, but still abduction is not improving. And then we were asking families to accept whatever we have achieved, you know. But of late, we found that those patients had flexed elbows, and the moment you put pediraps, so some of them we did pectoralis major transposition as second stage, and we have found improvement in elevation. Yes, please.
Okay.
Who is this?
Sir, me only. The third question is, so earlier we used to do both the tendons. Now we are doing this teres major to infraspinatus and posterior capsule release. So you've shown.
Yeah. So the reason is, you know, we have seen in sports medicine patients where they have traumatic subscapularis tear, they have performed latissimus dorsi to subscapularis transfer. Okay. And they have the post-traumatic subscapularis tear patients, they behave almost the same way as these patients. They have limited elevation, they have flexed elbow, and their internal rotation is weak. Dr. Bazim Al Hassan from Mass General, and earlier he was at Mayo Clinic, he has shown good outcome after latissimus dorsi to subscapularis transfer. I have tried that in a few patients who were lacking internal rotation. We did not improve their active range much, although their passive range improved quite a bit. But that's why I leave lat dorsi, that if in future, if I want to increase the internal rotation strength, I can take this lat dorsi to subscapularis. That's one. Secondly, these patients where I perform infraspinatus teres major to infraspinatus, they can reach behind the occiput, but with a bit of cheating, they kind of bring the head little bit anteriorly and to reach. So it's not a very easy external rotation, but they struggle a bit. So they had some weakness of terminal external rotation with arm abduction. So I want to improve that, and that's why I performed both these tendon transfers. Now, I had a word with Dr. David Chuang in Barcelona about this. And he is performing almost similar set of surgery in all his patients. And then I explained to him that I differentiate because not in all patients you need double tendon transfer. We get good results with isolated post-anterior, the subscap release and tendon transfer in typical of palsy. And he was also surprised, and he said that I'll start trying this test. What question he asked me is what is the improvement when you perform pect major transposition in isolation without doing infraspinatus transfer? So I did not have that data at that time, but when I came back and I looked at it, the average improvement after pectoralis double tendon transfer was 50 degrees, while it was only 22 degrees with pec major in isolation. So he told that we should do double tendon transfer because the second only isolated pec major is not strong enough to provide, and these patients have a subtle posterior instability as well. So so that is his thinking, you know.
Okay, sir.
Yeah, so that's why I reserve lat dorsi to because if I want to give some active subscapularis strength, then I can transfer it.
Okay.
And posterior capsular release, yes. So there's some of these patients when you check them, and you will realize that they lack 45 degrees or 50 degrees of passive internal rotation, and they cannot reach midline or tummy even with flexing the wrist. So I think these are the patients where we should release the posterior capsule. The posterior capsule, when it is tied, it itself pushes this humeral head in front. it itself contributes to the anterior instability. So we cannot do open posterior capsular lengthening because we have to go through the rotator cuff. So arthroscopic release is the key, and they have a very nice landmark that the subscapularis and biceps at the top, and they go behind, and there are postero-inferior and antero-inferior glenohumeral ligaments. So they stop at the postero-inferior ligament. So they release the posterior capsule. The interval at the inferior pole is the one where this axillary nerve lies very close. So they stop there. And you can see spontaneously the passive internal rotation improves.
Right, sir. Thank you, sir. Sir, one last question is about your way of managing elbow FFD.
Elbow FFD.
Right, sir.
So now we had a symposium on this elbow FFD, and we found that less than 30 degrees of elbow flexion deformity is well tolerated. What I have found that the patients with internal rotation contracture, their arm is persistently internally rotated, and there a small degree of elbow FFD is also cosmetically alarming for the patient. And so they will complain, now we want to correct the elbow, we want to correct the elbow. But the moment you correct the arm by tendon transfer, shoulder reband, the pointing elbow will go posteriorly, and then they will not come for the second stage operation if it's a minor degree. Secondly, when the more than 30 degrees elbow FFD is there, so far we have been doing biceps lengthening, Z lengthening of biceps at the elbow. But through the research of Dr. Roger Cornwall in Cincinnati, they have found that denervated muscles have failure of elongation. And in the elbow flexion, the brachialis muscle is more denervated. It has more muscle content than the biceps. And so it is more contracted. So now we have started doing a release of brachialis from its insertion. And the brachialis can be transferred to biceps, so that you release the elbow FFD at the same time you are not losing the elbow flexion strength. Dr. David Chuang, he does brachialis release, and in the setup where the triceps is weak, he shifts this brachialis to triceps. So provided they have good brachioradialis function, so that they can reach to mouth with the forearm pronated. But if you have brachioradialis weak, then these patients after brachialis transfer might need a free gracilis transfer to improve. So for all other purposes, you can try with brachialis release and transferring it to biceps, and then giving serial cast, and that would help. If you come across very neglected patients in their adolescence, there is some role of excision of the tip of olecranon, because there are studies which have found that the olecranon has overgrown because it has remained flexed. So there is a extension block, and there are some doctors who just safeguard the triceps and cut the tip of olecranon, and they see improved extension. So they do CT scan before the surgery, and they do this procedure. So you can try these things. Yeah.
Thank you so much,
So,
sir.
Sujit is asking, did you find any observation why elbow extension gives anterior stability, sir? So Sujit, this was my hypothesis, that is biceps becoming anterior stabilizer, because it gets constrained at the elbow joint. It now functions at the shoulder joint. Few other authors, let me have a sip of coffee. Okay. So few other authors, for instance, Dr. Basim Al-Hassan, or some Indian authors, they told me that this might be due to the lever arm effect. Lever arm means when you extend the elbow, the whole arm, length of arm becomes a lever arm. Now this, when the elbow is flexed, this lever arm is shorter for elevation. And then they ask me, you try to elevate arm like this. It's very easy, and elevate like this is a bit difficult. It doesn't move further. So by putting an elbow extension splint, we are increasing the length of lever arm, which facilitates the elevation. But I have seen many patients where I have done this pec major transposition. They were here and now they are here. So they improved in their abduction by 90 degrees, but still their elbow is flexed and still they can do shoulder elevation. So because of that, I am not very convinced about the lever arm theory. The other factor the people have suggested is in triceps length. So when the elbow is flexed, they feel that the triceps is contracted. I mean the triceps is stretched. The triceps inserts on the inferior capsule of the shoulder joint, and this inferior and posterior capsule gets tight when they try to elevate with elbow flexed, and that kind of pushes the humeral head in front. And the moment you put an elbow extension splint, the triceps gets relaxed and it releases the inferior capsule and let the humeral head come behind. So again, the same explanation that there are some patients who do not have triceps, triceps weakness at all. And how you would explain this improvement with still elbow is flexed. So these are the two theories. Now we are trying to study the ultrasonic needle placements in this muscle simultaneously when the elevation is happening, that what muscles are contracting and what muscles are relaxing. We are collaborating with IIT Gandhinagar, and they have very state-of-the-art ultrasonic machines. The problem is when you put a paddy wrap or elbow extensions, it's difficult to put these needles in. So we are also designing kind of push elbow splint so that the front of elbow and the posterior arm remains open while just this splint is given block from the posterior elbow. So maybe we will do this and we'll continue this research. I'm waiting for Dr. Shalin to come. He has great understanding of this biomechanics part, so he will help me with for our further collaboration with IIT Gandhinagar. So Prakash is asking, please clarify which group of patients you would perform pec major transposition. In a patient, some degree of interrotation contracture, won't pec major transposition make it worse? Yeah, so first and foremost, the patients, these patients do not have interrotation contracture, so they have full range of passive external rotation. So they don't have interrotation contracture first. Now, they have some degrees of limited internal rotation, or they have some degrees of posterior capsular contracture when we perform this surgery, okay? And they have limited elevation. So pectoralis major transposition is performed in a patient where elevation is limited and they have good degrees of external rotation. Now, some of them, they need some cheating in reaching behind the occiput. So their external rotation with abduction is limited, but they have good degrees, more than 20 degrees of external rotation when arm is adducted, and they have full degrees of passive external rotation. So they don't have internal rotation contracture, okay? So as they don't have the internal rotation contracture, they will not get version with pec major transposition. In fact, pec major transposition works by rotating the humeral head a bit internally. It pushes it back, it brings it a bit down. And Roger Cornwall told me that probably this transferred pec major clavicular head is acting as an anterior supraspinatus to help deltoid elevation. And I agree with him, because if this transfer would have improved the anterior stability. We would see spontaneous elevation and improvement. But typically, we have found that this improvement happens gradually, and it is more pronounced between 6 and 12 months after surgery. So there is some form of motor relearning of transposed part of pec major as an elevator. And so that's why. So I hope, Prakash, you understand that there are two cohort, C5-6, internal rotation contracture. They have limited external rotation. There you release subscapularis. If it is too much, you might need to do part of anterior capsule release, coracohumeral ligament release, whatever, you release it. And then you transfer your conjoined tendon to infraspinatus or posterior capsule in order to give posterior stability in a typical C5-6 cohort. These patients where there is no internal rotation contracture, in fact, some of them have external rotation contracture. This patient, they do not have limitation of external rotation strength. They can reach behind the occiput. There you do pec major transposition. And if the child is needs some effort to reach behind, or they are cheating in hand to neck, then you also do teres major to infraspinatus transfer. Okay. The plaster immobilization is different. In typical tendon transfer, we give it in 45 degree of abduction and 90 degree of, 60 degree of external rotation. I tend to give plaster 90 degree elevation and bit of internal rotation in these patients. Gaurav, we used to give in 90 degree external rotation, but when I saw that the posterior capsule is tight, now I'm doing it in 60 degrees. So I give some degrees of internal rotation. And in patients where I do isolated posterior capsular release, we give like this, 90 degree abduction and 30 degree of internal rotation to stretch posterior capsule. So the position of spica is important, and we keep on changing based on the requirement. Prakash, I hope I'm clear to you on that point. And Sudhanshu,
yes, thank you.
Yeah, Sudhanshu is asking, kids with classical herbs, is it now safer to transfer one tendon rather than conjoined, so to have reverse tendon? See, classical herbs patients, we have internal rotation contracture, and if you see the internal rotation contracture, internal rotation comes from subscapularis, pectoralis major, the lat dorsum teres major to some extent. So there, by doing subscap slide and not cutting it at insertion, you are giving passive external rotation. There are a lot of studies which shows that subscapularis is tight subscapularis is the main element responsible for internal rotation contracture, not the ligaments, not the capsule. They are secondarily tight, right? So if you just do the capsular release and you don't touch subscap, then there is high chance that this internal rotation contracture would come back. So subscapular slide we are doing, and we are doing conjoined tendon transfer, but we are not touching pec major. We are not releasing capsule at insertion. We are not releasing tendon at insertion. So those cases, doing a conjoined transfer is safe. Now we studied, like me and Shaleen, that what happens on longer term when we do this MISR and tendon transfer. We followed them for 5 years, and we found that few of our patients had difficulty in reaching midline. They had to flex their wrist, and there we checked their preoperative thing, and we found that the patients with triceps weakness, patient with certain degree of wrist dorsiflexion weakness, they had this problem. So this patient had a subtle C7 involvement. So we concluded that in this patient, subscapular is not only tight but also weak, because lower subscapularis is supplied by C7, So here you have to be very careful. So those patients who have weak triceps, and weak wrist dorsiflexion, their subscapularies are tight and weak. So there, we just manipulate the shoulder under anesthesia and try to bring it to 60 to 90 degrees of passive external rotation. If it is not possible, then you go in front, you release the coracohumeral ligament and part of capsule without releasing subscapularis. So do not touch subscapularis because it is weak. So the moment you release it, this child will develop external rotation contracture and they will not be able to touch midline. So they will, of course, their external rotation would improve, but that will be at the cost of midline function. So the answer to your question is, we do conjoined transfer if there is no triceps or wrist dorsiflexion weakness. But we do isolated transfer when we found wrist or dorsiflexion or triceps weakness. And there again, we may not release subscapularis and we try to stretch out the capsule. And if needed, we do capsular release without touching subscapularis. Understand, Sudhanshu?
Yes, sir.
Yeah. So, okay. So do we have any other question? And thanks, Gaurav, for bringing those points. I'm sure that these points would be brought when we try to publish this. Okay, so thank you very much. If we don't have question, I would conclude today's session. And from next week onwards, we will have the deformity module. Next week, we have Dr. Cherry Kua talking on fibular hemimelia management. And after that, Dr. Vasudevan from Palakkad, he will talk about principles of deformity correction in pediatric population. He is a champion of Elizaro frame and has done great work in deformity. So the next two Saturdays will be quite interesting. And I wish you all attend that. And from March onwards, we will have a new set of curriculum. We will repeat. We'll start with the pediatric hip and then trauma and CP infection with new faculties. Okay. So have a good day and please post your questions to me directly if you have. I will happy to answer them and it would help me also. Take care. Good day.